Welcome to today's webinar. I'm Joyce Coleman, Executive Director of the Vasculitis Foundation. We are glad you could join us today. Just a few housekeeping items before we begin. Please ensure you click on the full screen icon in the upper right-hand corner of your computer screen in order to capture the optimal screen resolution for today's presentation. After Dr. Watt's presentation, we will host a Q&A session. Please submit your questions through the chat window or question box, and we will address as many of them as possible. Today's topic is updated recommendations for the treatment of ANCA-associated vasculitis. Our speaker is Dr. Richard Watts. Dr. Watts is a consultant rheumatology at Ipswich Hospital in the United Kingdom and a senior lecturer at Norwich School of Medicine and a visiting professor of rheumatology at the University of Suffolk. His research interests are in the epidemiology, diagnosis, and classification of the vasculitides, and he was the convener of the British Society for Rheumatology's working group developing the guidelines for ANCA vasculitis. He is also a member of the EULAR ERA working group developing guidelines for ANCA vasculitis. Dr. Watts, welcome to the webinar, and thank you for speaking with us today.
Thank you very much, Joyce, for that very kind introduction. I don't have any conflicts of interest except to say that I have in the past been a consultant to Roche Pharmaceuticals. In this webinar, I'm going to discuss the current approaches to treatment, in particular focus on the use of rituximab, consider the role of steroids and their doses, and discuss how we might prevent some of the side effects from our treatment agents. I'm sure you all know what ANCA vasculitis is. There are three main types of ANCA-associated vasculitis: granulomatosis polyangiitis, previously known as vagus granulomatosis, microscopic polyangiitis, and eosinophilic granulomatosis with polyangiitis, formerly known as Sjögren-Strauss syndrome. These three sorts of ANCA vasculitis share some clinical features, and therefore they tend to be treated similarly. It's worth reminding you that most of the data on clinical outcomes and treatment are derived from granulomatosis polyangiitis, GPA, and microscopic polyangiitis, MPA. There's been relatively little research on the treatment of eosinophilic granulomatosis with polyangiitis, although that is changing, and we're beginning to consider that that might actually be a different condition from the other two forms of ANCA vasculitis. The aims of management are to induce remission, that is to control disease, to maintain the control of disease. It is also important that we recognize and treat relapse early, and of course we're very interested in avoiding drug toxicity. So what is the overall treatment strategy? And this is a slide that's taken from a single center registry of patients based in Norfolk, and shows the survival of patients with ANCA vasculitis up to 15 to 20 years. There's obviously a pre-diagnostic phase where really management strategy is not so much aimed at drug treatment, it's aimed at improving access to physicians with interest in vasculitis, and therefore getting a diagnosis as quickly as possible, because early diagnosis probably leads to a better outcome, and certainly leads to better treatment, earlier treatment, and easier treatment. So there's a pre-diagnostic phase which we should try and minimize. There's then an induction phase, followed by a maintenance phase, and then a very long-term follow-up phase. Now, there are some challenges that remain. We have clear-cut strategies and have had strategies for treating ANCA vasculitis for a number of years. However, we have a number of challenges. This is data from Rashid Luqmani's group in Oxford, looking at the outcome of patients with vagus granulomatosis, as it was then called, versus controls. And these are patients who are registered in the UK General Practice Research Database. And it shows that cumulative survival for patients with vagus granulomatosis is much worse than the background population. And therefore, one of the aims of modern development and treatment is to try and move the green line towards the blue line so that there is no excess mortality in patients with ANCA vasculitis. Similarly, we know that patients with ANCA vasculitis relapse with time, and this is data taken from the European Vasculitis Society studies, the long-term follow-up thereof, showing that the cumulative incidence of relapse increases with time up to about 8 years, and somewhere around 50% of patients will have relapsed 8 years from diagnosis. And clearly, we wish to reduce this relapse rate towards 0. So that line needs to be moved down. The green line on the left moved up towards the control. And by doing this, we should minimize mortality and minimize relapse. Over the last 2 to 3 years, as Joyce mentioned, there have been 2 new sets of guidelines. The first was produced by the British Society for Rheumatology and published in 2014. And more recently, the European League Against Rheumatism, EULAR, and the European Renal Association, ERA, and the European Dialysis Association, EDTA, have produced recommendations for the management of ANCA-associated vasculitis. There's not a great deal of difference between these 2 sets of guidelines because they were published relatively close together and shared some overlapping membership. It should be borne in mind that some of the recommendations and some of the use, particularly of rituximab, is very much based on European practice, which will be different from American practice, primarily reflecting different healthcare systems. So how did we conduct the EULAR-ERA literature review and develop the guidelines? Well, we started off with a Delphi process amongst the group to try and determine which questions we thought were important to develop guidelines about. Then our fellow, Max Yates, who was the first author of the paper, conducted and did a literature review and did much of the work. He did an extensive literature search using Medline M-based databases and Central, and he identified originally 1,278 reports mentioning ANCA-vasculitis. He removed those that were simply case reports and left him with 361. He checked those for clinical relevance, which in fact removed a large number of the 361, and he was left with 82 clinical studies to review. He then reviewed these papers for a rigor to ensure that we were only including studies that had high quality data, and we had a final pool of 44 papers from which to generate the guidance. We also analyzed the data and the clinical trials reported in each paper using a standard process. These are the EULAR standard operating procedures for developing and reviewing guidance. And essentially we categorized evidence in 1 to 4, 1 being the highest level of evidence, which is basically derived from meta-analysis of a number of randomized controlled trials. Group 2 is there's at least 1 controlled trial without randomization, 3 is from descriptive studies, and 4 is expert consensus. And then we developed strength of recommendations based on this. So strength A is the strongest evidence and strength D the weakest. And this enables us to give some indication as to the strength and of the evidence base behind each of our statements. We developed 15 statements, and I'm not going to go through all of them in a great detail. I'm going to focus mainly on the therapeutic ones, but as I understand there are a number of patients on the group, I will cover most of the other ones in passing as well. The first one may seem relatively self-evident, but in fact isn't. The first recommendation was that patients with ANCA-associated vasculitis should be measured in close collaboration or at centers of expertise. And fairly obviously this is very much a consensus statement and not much evidence base behind this, but most of us and all of us believe in this. And it's quite important in that in many areas of the world, patients with vasculitis do not have ready access to people who are expert in managing vasculitis. And therefore we thought this was a particularly important recommendation to include to try and encourage physicians who are seeing the occasional patient with vasculitis to at least collaborate or be in contact with their neighboring center. And of course, if patients are aware of this, then they can also talk to their physician and say, have you been discussing my case with somebody who has got more experience than perhaps their physician has. The second one is actually quite interesting. It's around the role of biopsy. Many patients do have a biopsy to confirm the diagnosis. Sometimes a biopsy is not possible or is not done, but clearly a biopsy is very desirable in order to establish the diagnosis very firmly. And also, it's particularly important for patient relapses is to confirm that this is a relapse and not infection or some other process masquerading as a relapse of vasculitis. So we would strongly recommend a biopsy where at all possible. A caveat is that a biopsy should not be delayed the treatment should not be delayed unduly just to obtain a biopsy. If the diagnosis is reasonably secure and that your patient is deteriorating, then treatment should be started and the biopsy can be obtained afterwards. So one shouldn't be waiting weeks to get a biopsy just to confirm the diagnosis. 3. Right. The first of the treatment recommendations, going back to the graph you'll remember that showed a remission induction as the first phase, we'll talk about remission induction for new onset vasculitis. Now, we categorized vasculitis into 3 major groups, which was organ or life-threatening vasculitis, patients with non-organ or non-life-threatening vasculitis, and those with severe renal disease or pulmonary hemorrhage. The definition of non-organ or non-life-threatening vasculitis has changed since the previous iterations of guidelines, in that by non-organ and non-life-threatening patients are those who only have the mildest condition. So a patient who has inflammatory eye disease, we would now consider as having organ-threatening disease because it's potentially sight-threatening. Similarly, a patient who has bone destruction due to sinusitis has got organ-threatening disease. There was a view in the past that such patients had did not have such severe systemic disease and could therefore perhaps be treated with drug regimes other than cyclophosphamide and steroids. But we now tend to view that all patients should be considered to have severe disease, i.e. organ or life-threatening disease, unless clearly proven otherwise. So we turned the emphasis around. The strength of evidence for treating patients with either cyclophosphamide or rituximab is really very strong for both a GPA and MPA, being level 1A, which is the strongest one can get, whereas EGPA, it's much weaker. And that's primarily because there have been very few trials that have solely focused on EGPA, and there were no EGPA patients in the UVAS group of trials, and they've generally been excluded. So new patients should generally receive cyclophosphamide or rituximab. What's the rationale behind that? Well, cyclophosphamide has been a classical drug, and the classical approach has been based on the Cyclophosphamide trial, which was published a good 10 years ago now, and was looking at the role of cyclophosphamide and the duration of cyclophosphamide treatment in patients with new onset ANCA vasculitis. And the classical approach, therefore, is intravenous or on occasions oral cyclophosphamide combined with glucocorticoids for 3 to 6 months, and then azathioprine. Although other maintenance agents such as mycophenolate, methotrexate, and leflunomide have been considered and used. And this approach results in approximately a 90% remission rate. Although, as I said earlier in the talk, there are still concerns about the overall mortality and the overall relapse rate. So cyclophosphamide, this regime is not ideal from those perspectives. Equally, we all know that cyclophosphamide is associated with significant toxicity, such as hemorrhagic cystitis, infertility, and infection. So there's good reasons for considering alternative drugs. The alternative drugs that have been tried and been shown to be effective is rituximab, and in 2010 there were 2 studies published in the same issue of the New England Journal of Medicine, one from Rachel Jones and colleagues in Cambridge, looking at new onset ANCA vasculitis with renal disease, and they compared rituximab given once weekly for 4 weeks with intravenous cyclophosphamide for 3 to 6 months, and then azathioprine, i.e. the classical Cyclophosphamide approach. The graphs on the right, the top one shows the remission rate, with the rituximab group in red and the control group in blue, and you'll see that the two lines essentially overlap and there's no significant difference between the two. Similarly, if one looked at the time to the first severe adverse event between the rituximab group and the control group, again there was no significant difference between the two. If one looks at sustained remission rates, they're the same, and the death rate was the same in the two groups. So one could conclude from that study that rituximab was certainly less effective than cyclophosphamide. The other study was, and then the study has now had a long-term follow-up, which Rachel Jones published last year, and showed that following the patients out to 24 months, there's no difference in overall survival or development of end-stage renal disease between the rituximab group and the control group, and therefore the two are similar. What they did show, however, is that when B cells return, rituximab is of course a B cell depleting agent. It's known to deplete B cells for a number of months after a course of treatment, and the concern has always been whether the disease recurs as B cells reappear in the peripheral blood. And it would appear that as patients' B cells return in peripheral blood, the condition returned and patients tended to relapse. So Rituxvas in the UK was encouraging and suggested that there was a role for rituximab in the treatment of that group of patients. Simultaneously, John Stone's group from the States published in the same issue of the New England Journal of Medicine the RAVE study, and they took 197 new or relapsing patients with GPA or MPA. They did not have severe renal involvement, nor did they have lung hemorrhage, and this is a randomized double-blind controlled trial of rituximab versus oral cyclophosphamide. Their primary endpoint was remission and steroid withdrawal at 6 months, and in all patients, 62% of the rituximab group achieved a primary endpoint compared to 55% of the cyclophosphamide group, and that was not statistically significant, whereas in relapsing disease, the response rate was 67% for the rituximab group and 42% for the cyclophosphamide group, and this was significantly different. And this therefore supports very much the use of rituximab preferentially in relapsing disease, but also supports the fact that rituximab is no worse than cyclophosphamide for all patients. One of the more interesting observations was that the adverse event rate was similar between the two groups. One would have anticipated that the infection rate would have been greater in the cyclophosphamide arm than in the rituximab arm. However, this was not the case and suggests therefore that the toxicity may not be so much the cyclophosphamide group due to cyclophosphamide, but actually due to the steroids that we give, as both groups of patients had a similar steroid treatment regimen. Unizoni has recently published a reanalysis of the RAVE data looking at outcomes based on ANCA type. Previous analyses were done based on the clinical type GPA versus MPA, whereas there's more recent evidence that suggests that outcomes may be as much determined by one's ANCA type proteinase 3 versus myeloperoxidase ANCA. And this data suggests that the proteinase 3 ANCA patients actually do much better than the MPO ANCA group, in that they develop have a higher rate of remission at 6 and 12 months in the rituximab treated patients compared to cyclophosphamide treated patients, and this was not true in the MPO ANCA vasculitis group. So this may be suggesting that we should consider different treatment regimens based on ANCA type rather than on the traditional clinical features. And this again looks at the outcome in the RAVE study with PR3 ANCA vasculitis. Again suggesting that this is a group that do well, particularly well when they receive rituximab. So that's the background for using rituximab in induction treatment in patients with severe vasculitis. In those with non-organ threatening disease, it's possible to use either methotrexate or mycophenolate mofetil, and there's reasonably good evidence from the NORAM study for the role of methotrexate in induction remission in the milder forms of ANCA vasculitis, and there's some slightly weaker evidence to use mycophenolate in this group of patients. So you've successfully induced remission, and you're maintaining your patient on remission, and they sustain a relapse. So for a major relapse, the suggestion is that the patient should be treated following a similar protocol to new disease, that is with glucocorticoids combined with either cyclophosphamide or rituximab. In many parts of the world, certainly in the UK, there's been a move in this situation to use rituximab rather than the second course of cyclophosphamide, based primarily on the data from the RAVE study. And again, the level of evidence for this approach is much better for GPA and NPA than for eGPA. And again, that reflects the non-inclusion of eGPA patients in the various clinical studies. The very severe group of patients, in other words, those with serum creatinine of greater than 500 micromoles per liter, or in the US 5.7, there's data suggests that plasma exchange should be used in that group of patients, and that's data that's derived from the PEXIVAS study, which suggested that plasma exchange had a role to, from the MEPEX study, which suggested that there was a role for plasma exchange in this group of patients. As many of you will be aware, the PEXIVAS study is a global study looking at the role of plasma exchange in this group of patients, and the recruitment to that study has just completed, and the results will be available towards the end of 2017. And that then hopefully will give a firm evidence base to the role for plasma exchange, and the guidance will need to be updated with when those results are being published. Plasma exchange is also widely used to treat severe diffuse alveolar hemorrhage, lung hemorrhage bleeding into the lungs, but actually there's very little evidence to support that because there have been no randomized controlled trials. The PEXIVAS study does include patients with pulmonary hemorrhage, and therefore the question of whether plasma exchange is useful in that subgroup of patients is now being investigated. The question, of course, is what do we do to maintain remission in our patients? And the recommendation from the EULAR group was that steroids should be continued in combination with either azathioprine, rituximab, methotrexate, or mycophenolate mofetil. Azathioprine was the agent that was used in cicazaram and has very much been the traditional remission maintenance agent in combination with glucocorticoids. Methotrexate, mycophenolate mofetil, and indeed leflunomide have all been tried and generally have been shown not to be any significantly better than azathioprine. Rituximab is, of course, the new kid on the block for remission maintenance, and I'm going to discuss that in slightly greater detail in a moment. But the trials basically of methotrexate, mycophenolate, and leflunomide did not provide convincing evidence that either any of those drugs are significantly better than azathioprine, and many people have now reverted back to using azathioprine as their first remission maintenance drug, reserving methotrexate and mycophenolate or leflunomide for those patients who are intolerant of azathioprine. So what about rituximab for remission maintenance in relapsing vasculitis? Well, there are obviously a number of strategies one could adopt for the use of rituximab in this situation. One could use rituximab as induction therapy and then wait and see what happened and repeat treatment only as need be. One could use rituximab in a protocolized fashion every 4 to 6 months for a pre-specified period of time. Or one could wait until one of the markers of vasculitis, such as ANCA, became positive again, or the B cells returned to peripheral blood circulation. This is some observational data from Rona Smith and David Jane's group in Cambridge, looking at 2 of these received rituximab, which was then only repeated on relapse. Group B is a group that was treated with 2 grams of rituximab and then received a gram of rituximab every 6 months for a total of 2 years, therefore receiving a total dose of 6 grams. And the green line represents Group C, who were patients treated as Group A, but then relapsed and then were treated as Group B. What you will see is that there's quite a clear, significant difference between the patients who received a protocolized course of 2 years of treatment of remission of rituximab compared to those who were treated only on relapse. And therefore, this is the approach that the EULAR group and the BSR group advocated, or there should be some form of protocolized treatment with rituximab. Subsequently, the main Ritsen study was completed by Loic Guillemin's group in France, and there is a RITUXVAS study which has finished recruitment, Rituximab study, which has finished recruitment in the UK but is yet to report, both of which address the question of what is the evidence for this approach of rituximab maintenance, comparing it against conventional azathioprine maintenance. So main Ritsen, which is Loic Guillemin's study, was published 2 years ago in the New England Journal of Medicine, and he compared rituximab versus azathioprine for maintenance, and he allocated patients to receive either rituximab 500 milligrams at days 0 and 14, and then at 6, 12, and 18 months, or they received azathioprine 2 milligrams per kilogram for a year, and then the reducing dose regime, and treatment stopped at 22 months. Primary endpoint was at month 28, and as a definition of relapse, patients were only randomized once they were in complete remission from their induction therapy. So he enrolled 118 patients and was able to include 57 patients in the rituximab arm and 58 patients for analysis in the azathioprine arm. This slide shows the main conclusions from the study and shows that there was a reduction in relapse rate in the rituximab arm compared to the azathioprine arm over the course of the study, both in terms of major relapse or in terms of minor relapse, suggesting therefore that rituximab has a benefit, a treatment benefit over azathioprine. It's worth noting that he used 500 milligrams infusion, whereas the standard dose that's certainly been used in the UK and I think also in the USA is a gram. This is practice that was extrapolated from rheumatoid arthritis. As you will have noticed earlier, there have been 2 regimes used for induction therapy of rituximab, 375 milligrams per meter squared for 4 weeks, or 1 gram twice. And this reflects different practices. The 375 milligrams per meter squared regime came from oncology practice, where it's a standard lymphoma regime. The 1 gram twice regime was initially developed to treat rheumatoid arthritis. There's data from, again, the Cambridge group suggesting that there's no clinical difference in efficacy between the 2 approaches, and therefore many people prefer using the 1 gram twice approach because it involves fewer infusions and is slightly cheaper. But there's no hard evidence as to why 1 gram should be used, and the French group chose to use 500 milligrams and clearly shown that 500 milligrams is effective. Whether 500 milligrams is as effective as 1 gram is a question that the answer to which is not known. Looking at adverse events between the 2 groups, there was no significant difference in adverse events between the 2 groups, and again, importantly, in infection, there was no difference between the 2. So what about steroids? We've been using steroids for many years. We use a lot of steroids. There are hints now that steroids are actually responsible for a lot of the infection problems in our patients with vasculitis, perhaps even more so than cyclophosphamide. We'd always assumed it's cyclophosphamide that's responsible for the infections, not steroids. But data from the rituximab studies, where there have been protocolized steroid courses in both arms, and rituximab versus other immunosuppressants, and the pre-treatment thoughts were that the conventional immunosuppressive arms will be associated with greater risk of infection than the rituximab arm was not borne out. Therefore, we're now beginning to seriously think the steroids are the problem. This shows a fairly typical steroid reduction protocol as used in many of the recent trials, starting at 60 milligrams per day and tapering down to 5 milligrams per day by week 26. There are studies ongoing looking at the lower dose steroid regime. One of the arms of Pexivas is a reduced steroid arm, and there's a study in London looking at an almost steroid-free treatment approach. So I think the steroid doses that we use in the future will be reduced. So what about other recommendations? How long should we continue treatment for? Most studies have a protocolized endpoint. There's no hard data to support how long we should continue treatment for. The consensus of the writing group was that treatment should be continued for at least 24 months following induction of sustained remission. So in other words, one's got to be pretty confident your patient is in remission, and then continuous treatment for at least 24 months thereafter. There are beginning to be suggestions that the duration of remission should perhaps be different in patients who are proteinase 3, PR3 antibody positive, as opposed to those who are MPO antibody positive, primarily because PR3 patients tend to relapse more than MPO patients and therefore perhaps require longer treatment. But those are suggestions that are currently require testing in the clinical trial setting. So we developed an algorithm for the treatment of vasculitis which summarizes much of what I've just been saying to you. If we take a patient with a new diagnosis of ANCA-associated vasculitis and has organ or life-threatening disease, and as I mentioned, this can be sight-threatening, hearing-threatening, bone-threatening, not just a conventional severe renal disease or severe pulmonary hemorrhage. These patients should be treated with cyclophosphamide or rituximab combined with steroids. Remission is achieved. There is a small group of patients who have non-organ threatening disease who may receive methotrexate, mycophenolate with glucocorticoids. And then there's a severe group who've got rapidly progressive renal failure or pulmonary hemorrhage who should receive, should be considered for plasma exchange in addition to induction therapy. Once remission has been achieved, then azathioprine or methotrexate or rituximab are used for remission maintenance, and the glucocorticoid steroid taper is continued. And then after 2 years, consideration should be given to tapering and withdrawing the azathioprine or methotrexate and to stopping rituximab. Patients who relapse get retreated as indicated before. There are a few patients who are refractory to conventional treatment, and those are patients in whom there should be an expert opinion sought. Care should be taken to reevaluate the diagnosis. Is it actually right? Is one treating the right condition? Consideration would be given to optimizing treatment as the patient had an optimum regime of cyclophosphamide, rituximab, and steroids, and consideration should be given to alternative treatments. So that algorithm summarizes much of what I've said over the last few minutes. There are a number of other items that we discussed that relate more to long-term strategy and prevention of side effects, and we produce recommendations for those. One of the key ones is that we recommend that structured clinical assessment should be conducted, preferably using some kind of outcome form such as the Berman Vasculitis Activity Score. Even if you don't formally calculate the score and use that to generate a number, the structure of the clinical assessment means you have to assess each organ in some detail, and therefore you're likely to come to a comprehensive assessment which will then inform your decision. There's been a lot of debate over the years since the discovery of ANCA as to the usefulness of ANCA in determining treatment changes. The group was of the view that clinical assessment and determination of disease activity by clinical means is more important than altering treatment based on the change in ANCA theta. So although many of us do actually measure ANCA regularly, this is a much less useful indicator of the need for a change in treatment than actually the clinical assessment of the patient. And therefore there's probably less need for ANCA testing in this situation than previously suggested. A number of recommendations were made about side effects. Patients with cyclophosphamide, as well known, are prone to developing hemorrhagic cystitis, and when given substantial amounts of cyclophosphamide, to the development of bladder tumors, and therefore unexplained hematuria, particularly unexplained isolated hematuria in patients who've received prior exposure to cyclophosphamide, should be investigated with cystoscopy to look for evidence of either hemorrhagic cystitis or a uroepithelial malignancy. We've also recommended that there should be an assessment of cardiovascular risk. The ANCA vasculitis is an inflammatory disease. The rheumatologists are now well aware that all inflammatory conditions are associated with increased risk of cardiovascular disease. Vasculitis is, of course, associated with abnormalities of the vascular wall and the endothelium, the lining of the blood vessels. And therefore, it's particularly important that patients should be assessed for cardiovascular risk, because this will, ANCA vasculitis will increase their risk of cardiovascular disease. One can control the ANCA vasculitis, but it's also important to control other risk factors for cardiovascular disease, such as smoking, diabetes, and hyperlipidemia. So we recommend that on a periodic assessment. In the UK, we tend to do that on an annual or biannual basis. One further point about rituximab is that hypogammaglobulinemia is not uncommon after treatment with rituximab. Low serum immunoglobulins, particularly IgG, is associated with increased risk of infection, and therefore we recommend that immunoglobulin levels should be tested prior to each course of rituximab and in patients who develop recurrent infection. There are now a few patients in whom permanent hypogammaglobulinemia and persistent infection have been induced, who are now on immunoglobulin replacement therapy. So one does need to be aware that if this does happen, it may not reverse just by not giving more rituximab. So in conclusion, there have been two new sets of guidelines produced. They're relatively similar. Much of it, both sets were produced in Europe, and therefore there's some European practice bias. Cyclophosphamide remains one of the keystones of treatment. Conventional classical therapy, 3 to 6 months of cyclophosphamide. There's a preference for intravenous therapy over oral therapy, and then switch to maintenance once in remission. There's now a strengthening evidence for a role for rituximab, particularly in new patients with high risk of infection or infertility, and in relapsing patients, rituximab is preferred over cyclophosphamide. If you are in the position to use maintenance rituximab, then the optimum regime seems to be regular infusions for around 18 to 24 months. Thank you very much, and I'm now willing to answer any questions.
Great. Dr. Watts, thank you so much. What an interesting presentation. While you were speaking, I just kept thinking, how can we get this information out to the treating physicians? So something to consider. At this time, we will open the Q&A session. I'd like to welcome Kaylin Young, the Network Manager for the VPPRN, and Ed Becker, our Marketing Director, to join us to moderate the Q&A session. Ed and Kaylin, are you on board?
Yes, we sure are. So Ed, if you have any questions to start us off, and for all of our participants attending, please feel free to submit your questions using the navigation bar. There should be a tab for questions. If you submit them there, then I will receive them on our side and be able to pose them to Dr. Watts.
Sure. There have been a few questions submitted, and interestingly, the one is just reflects what Joyce had just mentioned about disseminating disseminating this information out to the doctors, this person says, how can I get my doctor to read these guidelines and to understand them, because they will ultimately impact me?
That's a very interesting question. It is a challenge educating physicians. All one can do really is do this sort of session, have webinars, make the data and the information freely available. It's a challenge for any rare condition. It's how do you educate physicians? Because if it's a doctor who's only got 1 or 2 cases of vasculitis, well, yes, he clearly needs to learn about what he's treating. The bigger challenge is how do we educate physicians to make the diagnosis quickly when they'll say, oh, I never see a patient's vasculitis. The recommendations, guidelines are freely available. So the publications are freely available. It's talking about it, going to seminars, presenting this at meetings, and really just trying to get the message out. Say that there are strong guidelines, and I guess that to any individual patient, it's really saying, look, these are the guidelines. Am I having treatment following the guidelines? I think probably you may end up having to be quite pushy about it. It's not something as a physician we always terribly welcome, as a patient coming and waving great sheets of paper at us, but actually for rare conditions it's really very useful, and it may well be the only way. A difficult one.
Okay, thank you.
I think the other thing is Ed and Joyce actually just try and publicize the webinar and things like as much as possible. But there is an element of trying to take a horse to water and making it drink here, I'm afraid.
Thank you. And these two questions are kind of similar, and they reflect a lot of the questions. The theme that came in from them is they love this webinar, they love this information, but the person says, I just want to know what it means to me as a GPA patient and how my doctor manages my disease. What do these recommendations mean at the average patient level? And then bookending that, someone else wrote, I'm an MPA patient currently in remission. What specifically in this study is relevant to me as a patient in remission who wants to identify a possible relapse as quickly as possible?
There are two quite different questions, actually. Just remind me what the first one was, Ed?
Sure. The person says, I just want to know what it means to me as a GPA patient.
Okay, right.
Doctor will manage it.
So the average GPA patient, the problem is there's no real thing as an average GPA patient. And it depends a bit where you are in your journey with vasculitis. If you're newly diagnosed, say within the last 3-6 months, then you will probably be in the induction phase of treatment. That is, having steroids and cyclophosphamide will be the average still. Looking at most of the sort of audit type data that comes out and clinical trial data I've seen recently, the majority of patients are still receiving cyclophosphamide at the beginning rather than rituximab. And therefore, for the average patient with new onset GPA, you're looking at 3 to 6 months of cyclophosphamide and steroids, and then changing to probably azathioprine as a remission maintenance drug, and carrying on with that, with azathioprine, for probably 2 to 3 years. And during that 2 to 3 years, steroids will be reduced or possibly even withdrawn. That's probably the average patient with GPA. But it's really, because that is, if somebody asked me what's the average treatment strategy, that would be my question. That would be my answer. The trouble is there are a number of caveats around it. What specific organs do you have involved? What sort of age? What sort of risks of infection? What sorts of risks of infertility? Which may influence one's initial treatment. Similarly, what sort of response do you have to azathioprine and some treatment as to how long treatment carries on for. But broadly speaking, the average new patient is looking at 3 to 6 months of cyclophosphamide given intravenously with a steroid taper starting from high dose steroids down to moderate dose 6 months, and then 2 to 3 years of azathioprine.
Thank you.
The second question was, how do I recognize the relapse in MPA?
Mm-hmm.
Was that the gist of it?
Yeah, that's exactly it.
Again, most patients depend a bit on how you presented. Sometimes it's recurrence of initial symptoms. And most patients having had a major bout of vasculitis at the beginning are very aware of the symptoms that will first herald of their initial presentation, and therefore recognize the symptoms that might be suggestive of vasculitis recurring. Clearly, if you develop new symptoms, and as you'll be aware from reading the leaflets and booklets about MPA, it can affect many organs. Really, spotting relapse is being aware of symptoms, being aware of the change in your body, and thinking, could this be vasculitis, or could this be something, or is it something different? And actually discussing it through with your physician and raising that question, do you think it is? The problem is always differentiating vasculitis from infection and other things that go on.
Mm-hmm.
But it comes back to, I think, the patient having a high suspicion that you're not as well as you were, and it's very similar to what happened the first time round. That's not a 100% guide, but most patients recognize that as a pattern.
I see. Thank you. Last two questions. This has to do with one of the first recommendations. The patients with ANCA-associated vasculitis are managed in collaboration with centers of expertise. The question is, can you elaborate on what is meant in this recommendation? How is it different than what is being done now? Aren't ANCA patients always encouraged to be treated at a vasculitis center?
Well, the answer is yes, they're encouraged to, but I'm sure Joyce's experience, and probably yours, Ed, as well, is that there are a large number of vasculitis patients being treated by physicians in very isolated circumstances. It's certainly true in Europe, and my previous discussions with American patients, and I think Joyce in the past, and this is also true in the States. Is that not true, Joyce?
Yes, you're absolutely correct. You're absolutely correct in getting people to the vasculitis centers, and not just in the U.S. and Europe, but around the world.
Well, that's why it's number one. It seems self-evident that as a patient and as physicians we would say this, but actually you look at it and there are a lot of patients being treated in very isolated situations. Sometimes they have perfectly adequate treatment, but sadly there are a lot of patients who get suboptimal treatment because they're being treated in isolation. And it's something we do need to try and address, and that's why that's a key recommendation, because whilst it seems self-evident, there's a lot of that sort of practice still going on. And the Vasculitis Foundation, as Joyce has just said, had a lot of contact and a lot of calls about that issue. And the UK equivalent, Vasculitis UK, and the Lauren Cully Trust say exactly the same thing in the UK. There are a lot of people who are being treated by physicians who do not see much vasculitis.
Okay, thank you. And the last one is, you may have gone over this, but can you explain what the words level and grade mean on your slides?
Sorry, I did write at the beginning. It relates to the strength of evidence that we use to score the data. Medical literature, the results that are used to inform clinical decisions is not uniform. At one end, the best evidence, in other words, level 1 or level A evidence, there have been a number of controlled trials looking at the question, and those have all been pooled together, and an analysis has been done of all the trials together, what's known as a meta-analysis. And that provides the most robust evidence on which to develop a recommendation and a treatment approach. Then there are single randomized controlled trials that provide quite strong evidence, pretty strong evidence. Then there are studies which are basically, we've treated, say, 100 patients in this way and this is what happened. Then there are studies which just looked at a smaller number of patients. And then at the opposite end, there's essentially you get a group of people together in one room and you work out what they agree on, because there's no evidence, there's no clinical data to support the decision. So really that was a means of trying to convey to people how strong and robust the evidence behind each of those statements was. And therefore the evidence is strongest for things like the use of cyclophosphamide in vasculitis, because there are a number of trials which showed it works, but there's little data supporting, for example, the statement that everyone should be treated in the centre of excellence. Whilst it's something we all believe and you'll get a consensus, there's not an evidence base to it beyond that, and that's really what those levels and grades are trying to capture.
Okay, well that's what I have. Thank you very much, Dr. Watson. Kaylin, back to you.
Great, thank you. So we have had a couple of people submit questions. So the first is, I lost my sight during my initial diagnosis. My doctor plans to keep me on rituximab indefinitely. How safe is it on the drug beyond the 24-month term?
That is an interesting question to which there's not a straight clear answer. The 24 months approach essentially was taken as you have to stop at some point. You have to say, are we going to carry on with treatment for everybody indefinitely? Or do we stop at some stage? Now, it may be that 2 years is wrong. The concerns are always that drug toxicity, the side effects of drugs, are cumulative with the more drug you give. We learned this with cyclophosphamide the hard way. Cyclophosphamide was originally introduced in the early 1970s by Tony, and essentially a combination of steroids and cyclophosphamide turned what had been a very severe fatal disease, vagueness, into one that patients survived and turned it into a chronic disease. At that point, everyone said, oh, this is a miracle drug, we'll carry on with cyclophosphamide forever. It rapidly became apparent that cyclophosphamide carried on forever was associated with significant risk of bone marrow suppression, infection, and bladder cancer. And therefore, this was rapidly realized to be a bad strategy. And therefore, for the last 20 years, we've been reducing dose. Thus, we've got concerns about carrying on with immunosuppression indefinitely. You have to set a cut-off to 2 years with a balance between carrying on definitely and probably treating for too little time. So it is a trade-off. There's not a black and white, is it yes, no, safe. Beyond that, the side effects that tend to build up with time are low gamma globulins, in other words, dropping in the serum immunoglobulins, and cumulative infection risk. We've been using rituximab in rheumatoid arthritis for very long periods of time, because we've got a different treatment strategy in rheumatoid than we do in vasculitis, and we've been tending to treat on relapse rather than continuously. We've been treating patients out for 5, 6 or more years now, and we do begin to see problems with low gamma globulins and infection. Probably those risks are cumulative, but it is a trade-off, and I think most people's consensus guidance would be, if you're in remission and have been in remission after a 2-year course of rituximab, have a break. It's not to say you can't have some more, but have a break.
Great, thank you so much. So this is another interesting question. Is there an alternative to steroids if the patient suffers from severe myopathy due to the side effects of the steroids themselves?
The answer to that is yes, but it involves using the alternative drugs, methotrexate, azathioprine, rituximab, etc., and trying to minimize the steroid dose. There are steroid-free, low steroid regimes. Minimizing steroids is the key to that, and just minimizing the steroid dose. It's one of the reasons, many reasons, why we're keen to try and reduce the side effects of the steroids, because many of us now feel that actually the biggest side effects from our current treatment regimes relate more to steroids and the other drugs that we use. So it's minimizing the steroid. It's minimizing the steroid dose if your disease is active is otherwise active and only needs big doses. You have to optimize it treatment with one of the other agents. So yes, there are alternatives, but it's the other immunosuppressive agents.
Okay. Great, thank you. This is another one actually about the research behind this. Are there any studies that show a significant difference between stopping treatment, steroids and rituximab, after 6 months versus following up with azathioprine?
Sorry, can you just repeat that again? Can you repeat the question again?
Yes. Are there any studies that show a significant difference between stopping treatment, steroids and rituximab, after 6 months versus following up with the azathioprine?
So the questioner is asking, stop rituximab for 6 months and then use azathioprine. No, because the strategy that was used in main Ritsen was 2 years of rituximab versus azathioprine. And the strategy that's being used in rituximab is similar. It comes back to no. I don't think anyone's looked at it that way. It's either been rituximab and then nothing, or protocolized rituximab. It's an approach that you would be reasonable to consider, and I suppose that's in many respects what people do. If they're not allowed to give rituximab as maintenance. If you're not allowed because your funders won't let you give maintenance rituximab, they only fund induction with rituximab, then that's in many respects what is done in practice. But it's not in a question I don't think has been addressed in a randomized controlled trial.
Okay, great, thank you. So we are almost at the top of the hour. So there are several other questions, but what we'll do is I will catalog them and try to send them to you for quick responses so that we can send those back out to our participants that asked. But we would like to thank you so much for presenting and answering all of these great questions.
Okay, my
Joyce,
pleasure.
I'll turn it back over.
Great. Dr. Watts, thank you again for presenting today. We really appreciate it. I just want to thank Caitlin.
Was that the kind of thing you were looking for?
Yeah, absolutely. Yes.
Good. I was suddenly fearful when I realized it was mainly a patient audience. It was too technical.
No, I think you know, we have incredibly smart patients, and so we will be, we have recorded the webinar, and we will be placing it after editing in our library on the VF website.
Right.
I want to thank I want to thank Kaylin and Ed for their assistance. I want to thank all of the attendees for participating today. We're very happy to provide these educational programs for our community, and we thank you all for your support of the Vasculitis Foundation. Together we can make a difference and improve the lives of our patients. So thank you again for everybody for joining us, and have a great day.